to the weekly Gastro Echo Foundation and Project Echo meeting. Today, the topic is patient blood management. And we're once again very thankful to the Project Echo and University of New Mexico for helping us host these sessions. They are held weekly on a Wednesday. Every week is a different theme, and the themes are repeated depending on the particular theme every month or 2 or 3. And patient blood management is one of those themes that are hosted at certain intervals. So thank you very much and welcome to everyone who has come. Today we have, we currently stand at 42 registrations from 11 different countries. We've got people here from Ethiopia, Ghana, Mozambique, Namibia, Nigeria, Tanzania, Zambia, Zimbabwe, and South Africa. So it looks exciting. And beyond that, we are very fortunate to have one of the, if not the top person in the world on patient blood management, certainly the top person in the world on patient blood management when it relates to health economics, Professor Axel Hoffman, who is well known to us and who has been with us on numerous occasions before. Prof. Hoffman is situated in Zurich in Switzerland, where he's one of the professors there in more than one department. And he's got a background in some of the most in pioneering work, especially in Western Australia, on patient blood management and what it can do in a large population setting to patient outcomes, while at the same time leading to saving in money. Now, this work of Prof. Hoffman and many others has been recognized by the World Health Organization as an essential way to improve population health, noticing that anemia is a major problem in the world, that health costs are going up, that blood transfusion is expensive, a scarce resource, and often inappropriately used, and that patient blood management can answer all these questions in one fell swoop. So the WHO has therefore put together a steering committee to start working on a program that could have a global impact on improving this. And we're very fortunate to have Axel here today to share what this is all about, where we are going, and how this is going to change the world. Axel, welcome. Nice to have you here. And I'll hand the screen over to you.
Thank you for this kind introduction. Thank you, Vernon. Thank you, Chris and Cheryl. So let me just upload this. 2. Okay. And I think here we go. Can you see the slide?
Yes, we can.
Okay, so thank you again. And the topic, World Health Organization Patient Blood Management Policy Brief. It will be a very high-level presentation. It won't be a case. I know that ECHO usually does cases, but in case we have time, then Vernon will present the case. So let me just give you my disclaimer. Governmental and public institutions, blood services, professional societies, NGOs, and industries is where I receive fees, honoraria, and travel consulting for lecturing. I want to start early with the evolution of patient blood management in the year 1899. This is an article in the Annals of Surgery, the importance of blood examinations and reference to general anesthesia and operative procedures. And this Hamilton Fish said that anemics withstand general anesthetization and operations poorly. The ultimate result depends on the exercise of the greatest operative skill in order not to shed any blood unnecessarily. At the same year, there was at the Intercolonial Medical Congress of Australia, a article or presentation on the section of midwifery and gynecology, the saving of blood in gynae operations, and postpartum hemorrhage, its treatment, anticipatory and actual. And my method of treatment is first to try and cure the anemia and debility by tonics of iron. That's quite interesting. That's 120 some years ago, that there was already a focus on anemia management and blood conservation. However, there was the rise of the transfusion era with Karl Landsteiner, and in the year 1944, it has all developed to a degree that with fractionation, we got into a real blood industry or industry for allogenic blood products. And the focus I just shed light on kind of disappeared. Then Adams and Lundy came and said in 1942, in cases of poor surgical risk, it is suggested that transfusions be administered to pre-op patients to bring their level of hemoglobins above 8 grams per deciliter to about 10 grams to decrease their surgical and anesthetic morbidity. And then we got into blood donation campaigns, and finally, this is a work of a simulation work by Nicholas Roberts and colleagues, the global need and availability of blood products, a modeling study saying that currently the world needs about 305 million units of blood. That includes platelets, plasma, and red blood cells. And they talk of a chronic shortage because we only have a supply of 272 million. And they suggest that we need strategies for blood availability, especially in low-income and middle-income countries. However, there was a study years ago that challenged the status quo. It was a landmark study that basically demonstrated that millions of transfusions can be preempted. That was the Austrian benchmark study, where we looked at elective surgery and blood utilization in hip replacements, knee replacement, and coronary artery bypass graft surgery. And what we see here is every bar represents the transfusion rate of an institution for the relevant intervention. And you can see that there is an enormous variability between institutions in the transfusion rate for matched patients. And in fact, we found that there's a tremendous potential for reduction in all of these interventions. And what we also found in that study, and that's why it's a landmark study, I mean, we all knew that there is transfusion variability not only from that study, but from earlier ones. However, here we had a study design that allowed us to show what are the predictors of transfusion. And we found that 97% of all transfusions in the elective setting were predictable by the level of anemia prior to surgery, the volume of perioperative blood loss, and then the transfusion trigger or threshold. And we found that all three are modifiable risk factors. So the problem of anemia, blood loss, and also coagulopathy that leads to transfusion is something that can be modified. First of all, the anemia by augmenting the endogenous preoperative RBC mass, by reducing surgical blood loss by both surgical and anesthesiological/hemostasiological measures. And finally, the acceptance of low hemoglobin levels or restrictive transfusion regimens. As we said at the time, by the way, the three pillars have developed a bit further in the meantime. This is now 15 years ago. In 2010, the World Health Organization, and that's really the topic my talk is revolving around, the World Health Organization got wind of PBM in 2010 and endorsed it in their 63rd World Health Assembly with the resolution 6312, and basically said that physicians around the world should bear in mind that these 3 pillars should be applied wherever blood loss or profound anemia is being frequent. And then a year later, the Global Forum for Blood Safety had this conference on patient blood management with priorities for action on a hospital, national, and international level. However, 4 years later, the Director General of the World Health Organization found that patient blood management was not in place. There were still suboptimal clinical practices. Also, during the pandemic in 2020, there were several interim guidances that spoke about the problems that the challenge that we should manage demand for blood. And this is a paradigm shift in itself, because the first time the WHO said we should not focus on the supply for blood, but on the demand side. We should look at the bedside. Are we using the stuff appropriately? And they felt that good patient blood management will help to resolve the problem. So in 2020, they came up with the action framework to advance universal access to safe, effective, and quality assured blood products. And they had 6 strategic objectives. And one of them was the effective implementation of patient blood management to optimize clinical practice of transfusion. So the World Health Organization approached my colleagues and myself to establish an external steering committee with well-known experts in the field, and wanted to task us with the development of a patient blood management policy brief and a guidance document on PBM implementation, with the support of 70 international PBM experts. Vernon is one of them, and Chris is another one. And we said, basically, yes, it's a good idea. However, we don't agree with this objective the way it is being written or formulated. We said, number one, it's not to optimize practice of transfusion. In fact, it's not even optimizing clinical practice. It is there to optimize patient outcomes. And you will see later why this kind of hiccup between us and the WHO was very important and helpful. This falls in place with another publication that just came out a few weeks ago, a global definition of patient blood management in anesthesia and analgesia. It is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. And what you can see here, there's not a single mention of the word transfusion, because it's not about transfusion. It's about the patient's own blood and how we can better manage it in order to improve outcomes. So the drivers for this definition were these 4 entities: the International Foundation for Patient Blood Management, the Society of the Advancement of Patient Blood Management, the United States, NATA, which I think many of you are familiar with, and finally the Western Australia Patient Blood Management Group, that is officially registered in Australia. And since while we were working on that definition, it has been endorsed by a number of important societies around the world. One of them is the American Society of Anesthesiologists with 50,000 members. So coming back to our condition that we basically told the WHO to be accepted, effective implementation of PBM to optimize outcomes. They respected it because we said everything else is optimal blood use, and we have to make a clear distinction between the two. And why this distinction? And this is, again, a very important point or moment in my presentation, because patient blood management is much bigger than optimal blood use. In fact, patient blood management looks at anemia, iron deficiency, and also to a degree thrombocytopenia or pancytopenia, with 2.9 billion individuals affected. And there's another 0.6 billion people or more that suffer from one way or the other from blood loss or coagulopathy. Whereas those who might benefit from what is called optimal blood use are not more than 50 million individuals. That's about the number of individuals that is transfused with the 270 million components that we mentioned earlier. And if patients are hospitalized, the prevalence of anemia, blood loss, and coagulopathy is relatively high, and especially anemia can be up to 75%, especially in oncology patients. And we see there is little to no respect for the patient's own blood because we have these high prevalences and almost nothing is or has been done about it. And this is why we need PBM. Just one of the most vulnerable populations, anemia during pregnancy. It is the odds ratio for mortality with severe anemia is 2.36 times up compared to the non-anemic pregnant woman. And the interpretation that prevention and treatment of anemia during pregnancy and postpartum should remain a global public health and research priority. Or here is an overview of different surgeries where you see that anemia is common across all of them. In some populations, like an orthopedic, can be up to 50%, in specific conditions 65%, and as I said earlier, in oncology patients up to 75%. Also, when you look at what is the risk, I mean, it's increased morbidity, mortality, and cost. You can see this from this meta-analysis by Fowler and colleagues, who looked at almost 1 million patients from 24 different studies. 39% of them were anemic, according to WHO definition, and the anemia was associated with an almost 3-fold increase in mortality, 4-fold increase in acute kidney injury, twice as many hospital-acquired infections. In the subpopulation of cardiac surgery patients, the rate of stroke was about 30% higher. And compared to the non-anemic patient, the utilization of red blood cells was about 5 times higher. You can see it's a major driver, of course, for transfusion. The other problem is, of course, hemorrhage. William Halstead, famous for the Halstadian principles in surgery, said the uncontrolled hemorrhage is the only defense of the unconscious patient against the incompetent surgeon. And here we have an interesting study from Marco Ranucci from Milan, where he looked into the difference in outcomes in major versus no major bleeding in cardiac surgery. And you can see that the operative mortality in the major bleeding cohort was 5 times higher than in the no major bleeding cohort. And also other important outcome parameters show a significant increase in the major bleeding compared to the no major bleeding. We can say by and large that major blood loss is associated again with increased mortality, major morbidity, ICU and hospital lengths of stay, and of course transfusion. And we should always keep in mind that the majority of patients did not have blood loss until the surgeon stuck a knife into the patient. So on average, 75 to 90% is due to local surgical interruption or vessel interruption, and the remainder is acquired or congenital coagulopathy. What is also very sad, pregnancy-related death. 70% of pregnancy-related death are from hemorrhage, and this is data from the United States. So it's not only a problem in sub-Saharan Africa, it's also a problem in the US. And this is why for decades, blood transfusion was the default treatment when physicians were facing severe or profound anemia and or blood loss and or coagulopathy. And it is still the most common invasive procedure in hospitalized patients. However, we want to challenge the transfusion paradigm as well, and this was very important in connection with the WHO, and when we said we are only accepting the larger concept of PBM rather than the idea that it's just to reduce transfusions. We don't have the time to go into this in detail, but these are cardiac surgery studies looking at the dose response increase in adverse outcomes that are associated with this transfusion of red blood cells. You can see many of them report increased mortality with the amount of units given, but also other adverse outcomes. This is also true for non-cardiac surgery, including one study from Big Ferraris with almost 1 million patients here, showing increase in morbidity, mortality, and resource use. It's true for ICU patients. It's true for critical bleeding trauma patients. And it's also true for the yellow stuff, and also across many different patient populations. So the more you transfuse, the more of an adverse outcome you see. We can say that currently at least 60 observational studies with more than 6 million patients demonstrate this dose response increase with red cells, and there's many studies showing, again, similar effects with plasma and platelets. And this is a tabulation of all the adverse outcomes you can see from the literature, including those who have a very big economic impact, such as increased admission to the ICU or increased ICU lengths of stay and other things. So one might say, well, this is all observational. What about randomized controlled trials? And we know that for 20 years, we had many randomized controlled trials looking at restrictive versus liberal transfusion. They don't really look at the efficacy of transfusion or effectiveness. It's really looking at different levels of anemia tolerance, and subsequent transfusion. So they are asking, in fact, the wrong question when they want to show how effective or efficient transfusion is. Anyway, they did all these studies, and so my colleagues and I undertook a overview of all systematic reviews that could be found by the year 2020. And here's what we learned. Here's the 19 systematic reviews, and you see the turquoise color is every systematic review has a number of randomized controlled trials included, and in the turquoise you see the restrictive threshold range, and the pink you see the liberal threshold range. And what is obvious is that in many of these systematic reviews, there's an overlap between the groups. However, one study stuck out, that was that of salpeter, which really had a distinction between those less than 7 grams and those patients receiving more than a transfusion at a threshold of more than 9 grams. And this is made of the 3 very famous RCTs from Paul Hébert, Jacques Lacroix, and Candide Villanueva, all published in the New England Journal of Medicine. 2 of them were ICU patients, adults and peds, and the other one was in gastrointestinal bleeders. And when you look at the results of that study, you see that in the restrictive versus the liberal, total mortality was 20% lower, and the other endpoints were also significantly lower in the restrictive group when compared to the liberal. So after all of this, and this is what we told the WHO as a steering committee, we look at this triad of independent risk factors, A like anemia, B like blood loss, and C like coagulopathy, so easy to remember, A, B, C. They are independent risk factors for adverse outcomes. And if there's a lack of timely and effective management of 1 or 2 or 3 of them, then we run into the problem of transfusion. where we for years looked, I would say, exclusively to what is called the deterministic transfusion risks, such as ABO incompatibility or alloy immunization and anaphylactic shock, clerical errors, things like this. But now with the data I have shown you, just very briefly, we now see also the probabilistic transfusion risk in terms of mortality, also cancer recurrence. I haven't shown you the data, but they are out there, morbidity, multi-organ failure, etc., etc. So this needs disruption. Something has to happen. And disruption in the normal courses of healthcare. We cannot any longer tolerate A, B, and C and run into T-like transfusion. And we have shown 15 years ago, almost as a proof of principle, how this could be managed. And we used our knowledge and our findings, particularly in a large program in Western Australia. And Vernon in the introduction has alluded to this already. This is an observational study with more than 600,000 patients in the state of Western Australia. It was across the entire healthcare system, but the study was conducted in the 4 largest tertiary hospitals of the system. And we applied the 3 pillars in a more sophisticated way. We split it into pre, intra, and post-op, which makes it a 9-field matrix. Again, we don't have the time, but if you just Google the 3 pillars or the 9-field matrix, you will find sufficient material. Or you take a screenshot from this one and go into the literature. And we enrolled basically all emergency and elective medical and surgical patients in 4 tertiary hospitals in WO in Western Australia, sorry. And we applied the 3 pillars across these populations. And the results that we saw are very compelling. In-hospital mortality dropped by 28% in this ultra-modern hospital or healthcare system. Length of hospital stay was reduced by 70,000 stay days. Infection dropped by 21%. Myocardial infarction and stroke dropped by 31%. Readmission rate from a very small baseline of, I think, 1.2% increased by 6%. So 6% of 1.2. What we were able to show is a massively decreased anemia rate at admission, because anemia was taken care in that whole program primarily by GPs or in a pre-op anemia clinic in the hospitals. So it dropped to 14.4%. This was just the emergency cases where the window was very limited to tackle the anemia problem. We had a massive reduction in blood utilization. When we started the program, we had the lowest transfusion rate in the Western world, and we reduced it further by 41%. The mean hemoglobin threshold decreased from 7.9 to 7.3. We had a massive increase of single unit transfusions versus multiple unit transfusions. And the elegance, the beauty of the program was that we saved the system at least $80 million in activity-based costs. Just on transfusion, we have not valorized the additional massive savings from reduced complications, but my quick and dirty estimate is that this was at least another $100 million. So patient management reduces mortality and morbidity while saving costs. And so when we ask, why is there an urgency to implement PBM globally? Well, we have identified one of the world's biggest health burdens, this monster here on the left side. We have a solution for this problem with the 3 pillars. However, we have multiple barriers to implementation. The barriers, although this concept is compelling, it's a new paradigm. It's about cultural and behavioral challenges. It requires structural changes. Multiple stakeholders need to be managed. And there's also a problem and who takes on the responsibility on the state level or on a jurisdictional or political level. And so the World Health Organization says in the policy brief, the need to implement is really urgent. And it says there is so many adverse outcomes in connection with the anemia, in connection with severe bleeding, and for so many different patient populations. And it says there is an unmet need to manage and preserve the patient's own blood. For millions facing anemia, blood loss, and coagulopathy, transfusion is still the default therapy. This is despite evidence that the efficacy and safety of transfusions is suboptimal in many clinical settings. And PBM results in significant reductions in preemption of transfusion, in reduced mortality, and. So the WHO concluded that taken together, the problems of anemia and both chronic and acute blood loss and bleeding disorders represent one of the world's biggest, and here's the good news, largely preventable, but yet underestimated public health and health economic burdens. So with this multiple wins, the way forward is, and with these hurdles ahead of us, we have to underline and communicate the evidence about PBM and showing that it significantly improves outcomes for hundreds of millions. And we have to stress the economics by showing that we have multi-billion-dollar savings when we smartly reallocate existing resources. And when these two E's, the evidence and the economics, are in line, and they are in an exemplary way in line when we look at PBM, then the ethics are on our side. There's an obligation to offer a medical model that is beneficial for society at large, but also for highly vulnerable populations, individual patients, and even the blood donors, because we take off the pressure of that population, donor population. So that's what we want to employ in the future, the 3 E's, evidence, economics, and ethics, to get over the hurdles. And now we come back to the definition. This is again from the policy brief. And the policy brief clearly states that patient blood management addresses the problems of anemia, blood loss, and coagulopathy, A, B, and C. And then it basically repeats the definition that has been published in Anesthesia and Analgesia. That was one of my earlier slides. There's a little bit more of an explanation to the definition, or between, like, for instance, managing a patient's own blood through diagnosis and etiology-specific treatment of anemia. And then it concludes, it reduces the utilization of healthcare resources as well as expenditures, transfusion dependency, and the risk and complications of transfusion. So you see, we really moved away from the product focus. We have the patient now in the center, and we say, as a corollary of good PBM, you also reduce transfusion, but it's not and will be not the focus, because PBM is much bigger, as I said earlier. So here's the two paradigms in comparison again. The new paradigm says we've got to diagnose the underlying causes to manage and preserve the patient's own blood. This can be done with the 3 pillars, and this applies to this large population. The old paradigm replenishes patients with allogeneic blood components while mostly ignoring the underlying causes of the condition. And this is why we have a dotted line. Nobody cares, you know, this A, B, and C was not on the radar. And for most physicians and clinicians, it's still not on the radar. And this only refers to about 50 million individuals. And you can really see this is often in the absence of PBM, and clearly in the absence of optimum blood use, and often and in the absence of PBM. So the policy brief then says that all member states should act quickly through, and this is 194 member states, through their ministry or Department of Health to adopt their national PBM policy, install the necessary governance, and reallocate resources to improve the population health status and individual patient outcomes while reducing overall healthcare expenditures. This is a very rare situation that you get more for less money. This is what we see almost nowhere in, not only in healthcare, but in the industry or in the service world. Normally, when you want to have improved services, you have to add an increment of additional costs. Here you get more for less. And this is why the WHO decided to use the results from Western Australia. This is just a repetition of what I have showed you earlier, but it's in the center, one of the center pages of the policy brief, saying when we look at Western Australia, what has been done and achieved there, this must serve as a template for the rest of the world. So what is my summary? The potential for PBM is huge. It improves global population health, but also the clinical outcomes of hundreds of millions of single surgical medical and obstetric patients. It reduces healthcare costs by billions of dollars. It improves patient safety, advances patient education and empowerment, and it reduces significantly the demand for blood components and therefore the national transfusion dependency. And particularly in low-income countries and lower middle-income countries, it helps to mitigate some of the resource constraints in healthcare. What are the next steps? Well, the policy brief announces to develop a PBM implementation guideline that will serve as a framework for healthcare leaders of all member states. And here's the structure of this. This is not any longer called a guideline for some bureaucratic reasons. It has now renamed as a guidance. And the guidance will consist of 7 modules. What is PBM and what is not PBM? Who will benefit from it? The different, not only patient populations, but also institutions, the insurance world, the public health policymakers. Why is there an urgent need? I think I told you a lot about the urgency in this talk today. Who should take the lead and act in the implementation process? How would one develop nation-specific PBM implementation strategies? Because we have different countries with different resource levels and different epidemiologies. And finally, how to use a versatile PBM toolbox to build different national programs. For the same reasons as under point 5, we have to differentiate by regions. And last but not least, how does PBM support the concept of patient autonomy? So thank you for your attention, and I think I leave it to Vernon how to conduct the rest of that meeting, but that was my part. Thank you.
Axel, thank you very much for a fantastic overview. And also, I think we would like to thank you on behalf of our colleagues and our patients for the work you've been doing. I think it's really, really amazing. And at least one of the most exciting and important things that will change the lives of many patients around the world. So thank you for driving this. Axel is the spearhead and the chairperson of the steering committee, and it's really a wonderful privilege to work with him. Can I hear from the anyone in the audience if you have any questions or comments for Axel? Maybe I can start by asking, in terms of the time frame for this, Axel, what do you foresee? How long will it take to get something out via the WHO to all the countries so that they can really have a strong impetus to start acting?
So the deadline for delivery of the guidance is August 2023. And we all, including you, we were all waiting to start the work already in the end of 2021.
2020. Oh, yeah.
Yeah, and then there were enormous bureaucratic hurdles, and part of this was the hiccup I told you, I showed you today, when we said this is PBM and nothing else. It's not about reducing transfusion rates, and it was kind of an educational process. Anyway, to make the long story short, we have found a wonderful agreement now with WHO, and the last 2 weeks have been very productive. We are now working on a series of 8 little videos. Each of the video clips is about a minute and 10, a minute and 20 seconds. One is a teaser video about the importance and urgency of PBM, and then for the 7 modules that I briefly touched on, we will have an introductory video for each of those. And this will be also sent out to the experts, we hope by latest mid of August this year. And once this is agreed upon, then we go into the more detailed work. And I'm confident that we will deliver in time.
Fantastic. Great. Thank you so much. Please feel free to add any questions to the chat. I think while we wait for that, I'd like to quickly share a case that I saw very recently, and I've not had the chance actually to discuss it with a gastroenterologist or with a gynecologist or with any other specialist. So I'm just going to put it out here, and I would really be very interested to hear and see how people in the room would have managed or approached this case. So let's see. Right, so this was, like, as I say, very recent. I saw this patient late April. 31-year-old, healthy, athletic looking young woman, lawyer. She is not only looking healthy, she's a triathlete, takes part in Ironman and all these sort of competitions, with a previous medical history of iron deficiency. That's what she was referred to, and I'll give more details in a moment. Irritable bowel syndrome and polycystic ovarian syndrome. Family history was that her grandfather had colon cancer, a mother also had iron deficiency, had normal scopes, and her own history that in 2017 she wanted to donate blood but was deferred as iron levels were too low, and she did not take any treatment for that. In 2019 she had some abdominal cramps and symptoms, and eventually had a gastroscopy and colonoscopy somewhere in South Africa. I'm not going to say where. Everything was normal, but unfortunately no records were available, as the doctor who had done the scopes had emigrated. But she does mention that the person who did the scopes diagnosed her with irritable bowel syndrome, and she was placed on a FODMAP diet to minimize abdominal cramps. Further history revealed that she was a pescatarian. She ate almost no chicken or red meat. She had reflux, but was not on an antacid or PPI. She says on questioning that sometimes there was a little blood in the stool, but no history of hemorrhoids. There was no change in a stool pattern, no loss of weight, no change in appetite. And she says she used to donate blood at least twice a year for 4 years, but all of these episodes were before 2017, at which time they said no more. No history of menorrhagia. As a matter of fact, she's claimed that her periods were very mild, and she had been for regular pap smears and had seen a gynecologist, and there were no apparent problems. And there was also no bleeding history of any other kind, no chronic infection or inflammatory condition. In February of 2021, she felt burnt out during a very stressful time, and a psychiatrist found that she was iron deficient and also had low B12, and was referred to a GP. At that time, her HP was 11, ferritin of 5. The GP first gave her 4 months of chelated iron with no response, then 5 infusions of iron sucrose with an HP that remained virtually unchanged and a ferritin that went up from 5 to 20. She worked the GP, this is from the GP's letter. She was worked up for causes of iron deficiency anemia, including hemolysis, menstrual blood loss, but nothing found. And the GP suspected excess loss. She also said in a letter to me, she does report occasional but very infrequent blood spotted stools. She did previously have scopes done, but the doctor performed them as immigrated. And as I said, was no records available, no heavy bleeding, and she's also on a combined oral contraceptive. So in February of 2022, she had an HP of 7, iron deficiency confirmed once again, got 6 infusions of iron sucrose with a GP with very little response, and then referred to me. The symptoms she complained of, as mentioned often in my lectures, it's not just fatigue, but they can have many, many symptoms. She had all of these: brain fog, exercise intolerance, headaches, anxiety, hair loss, nails that break easily, dizziness, pre-syncope, and crave salty foods and ice water. Examination was completely normal, including the rectal exam. Urine was clear. And at that point in time, her HP was 10.9, serum ferritin 26. Note, again, my point I always make about the fact that these ferritins, the reference ranges with ferritin less than 15 are inappropriate. So this is a ferritin of 26, saturation of 6%. That's clear iron deficiency. And these tests came back later. They were done afterwards, but you can see there that parietal cell intrinsic factor antibodies were negative. The context was the combined B12 and iron deficiency. With the abdominal symptoms, celiac serology was negative. I didn't have access to know whether a duodenal biopsies were done, and a PNH screen was also normal. So what are the possible reasons for iron deficiency in her? Well, there's a dietary issue, no chicken or red meat. She's donated a lot of blood in the past. Maybe the little bits of blood in the rectum was contributing. Could she have high hepcidin and poor absorption from polycystic ovarian syndrome? She is a young menstruating female, and then she's also a triathlete. Could she have some March hemoglobinuria, crushing red cells under her feet, and or have GI bleeding, which is one of the ways in which endurance athletes sometimes get iron deficiency? So my question to you as the audience, what would you do now? Gastroscopy, colonoscopy, gastroscopy and colonoscopy. So we mentioned the last gastroscopy, colonoscopy was in 2019. Replace with higher dose IV iron, reevaluate after 6 weeks, or do a red blood cell isotope study to see if she's losing blood anywhere else. May I ask you guys to quickly in the chat, just put in 1, 2, 3, 4, 5, just to get an idea what the feeling would be. If anybody is brave enough to throw out an answer. Okay. Okay, so clearly speaking, I'm going to have to present this case to another crowd because this crowd is not fooled by this case. So my reasoning went like this. She was not currently donating blood. Last blood donation was before 2017, so that cannot be contributing. The diet would not lead to such poor response to iron infusions. It should easily be overcome by IV iron. The iron infusion should also have overcome the hepcidin effect of polycystic ovarian syndrome, and it didn't. The blood loss from endurance running is usually slower and should not be so severe, despite, in the context of iron replacement. But in contrast to that, the last scope in 2019 was normal. So, but the reality was that the iron response was not well explained. And this poor response to IV iron to me was unexpectedly poor. So I referred her for a repeat GNC scope, you know, and to see what was going on. So the gastroscopy was completely normal. Colonoscopy showed
terrible.
an apple core lesion in the ascending colon with histology, a moderately differentiated infiltrating adenocarcinoma. Surgery is planned for the end of June.
Terrible.
So, what is my take-home message? When things don't make sense, slow down, think again. One could easily be fooled here, and this is my experience, almost all the iron deficiency patients, or most of the iron deficiency patients that I get, who are referred to me as unexplained iron deficiency. And when I take a very thorough history, I usually find 3 or 4 different potential contributory factors. One can't just accept them as the cause. You must think, are they enough? Does it make sense? Here, the lack of response to multiple infusions with, as I hypothesized earlier, to me was the clue. And then if a patient is losing visible blood per rectum, I think one must really, really be very careful. So her so-called irritable bowel syndrome and abdominal cramps had a completely different reason. And I must say, it's a big shock for the patient's sake. But I'm also very thankful that I didn't leave it another 3 years for when the next scope would have been due. So I'd like to hear if there are any comments, perhaps from our gastroenterology colleagues. Chris, you look like you're so ready to say something. I'd love to hear what you think. But this case hit me hard. You know, I've often said I lost my own father with colon cancer, and he was diagnosed when it was metastatic, and he had almost complete obstruction. And the reality is we need to be aware and think. Chris, what do you think?
A couple of points here, Vernon. I think the focus always in patients with unexplained iron deficiency anemia, whether they've got GI symptoms or not, has to focus on the gastrointestinal tract, and a gastroscopy and colonoscopy is appropriate. Now, I must say that this is all now in our PBM GI guidelines, which have been completed, and I see Wayne Simmons is in the audience, and he's to be congratulated. So these are all now documented, and there's good advice on how to proceed. We often see this. A gastroscopy and a colonoscopy was done and was normal, but it doesn't mean the findings were normal. Firstly, what did the endoscopist do at the time of the gastroscopy? Did he take biopsies for H. pylori infection? Did he take duodenal biopsies for celiac disease? Those are the 2 very important issues which you will only see if you visualize the report. And secondly, as far as colonoscopy is concerned, we now have very strict criteria which will enable us to assess the completeness of the colonoscopy. Was the ileum entered? If the ileum wasn't entered, what were the criteria that the endoscopist used to confirm that he indeed was in the cecum? What was the colonic transit time? The time that it takes getting out the colon to make sure it was slow enough to pick up small lesions and perhaps even larger lesions. So a repeat evaluation of the stomach and colon is mandatory in these patients with unexplained iron deficiency anemia, whether they've got rectal bleeding or not. That is irrelevant. I would, before even looking for PNH and hemolysis, repeat the endoscopes. From the literature, even in the best of hands, the interval colon cancer rate, and that means colon cancers that develop within 1 or 2 years following a so-called normal colonoscopy, is 8%. So it is appreciable. These evaluations, endoscopic evaluations, are not perfect modalities. And particularly with colonoscopy, it is not only the skill of the endoscopist that is important, but the adequacy of the bowel prep is even more important. And these vary a lot between patient and patient. This is very tragic, but thankfully it was picked up, and it's not that uncommon to see this kind of situation. I might say in the history, the big alarm factor here right in the beginning was the grandfather with colon cancer. It's not in first degree index relative, but it is in the background. And that for me is a big alarm signal.
Chris, I think you've really given us fantastic commentary there. Thank you so much. Mashiko, I see you've got a comment too.
Thanks for that case. Very sobering. And I think you are right. And then sometimes I think people underestimate the possibility of a second pathology in a young woman who's obviously still having her menses. You know, it's very easy to write it off, especially if the patient has had bidirectional endoscopy. So Chris is quite right that we do tend to either review the records, but even so repeat top and bottom as a matter of fact, because I think it really is useful. The other thing about rectal bleeding, in our series, even with hemorrhoids, we have found, I think, 30% of patients will still have additional pathology, either or some other thing that will explain their anemia. So I think, again, patients with hemorrhoids or rectal bleeding should not dissuade people from scheduling a colonoscopy if necessary. And then I just wanted to ask Vernon, just for my own knowledge, if the patient has got PCOS, would we not expect a higher ferritin rather than lower ferritin?
Yeah, I think you're right. Sometimes you would get a higher ferritin, but not always. It's only a percentage of them. And also her PCOS, I'm also wondering about how bad that really is. I mean, she doesn't give a history of menometrorrhagia. There's nothing else very much. It's not as if that's really bothering her in any significant degree.
Yeah, and then the last comment, sorry, is that Chris mentioned the intubation of the terminal ileum, because I was also thinking, because she's young female with a hair loss and other features which can be accounted for by anemia, you need to exclude something like Behçet's, you know, something like that that would affect the terminal ileum and autoimmune disorder in a young patient. So again, TI intubation with biopsies is abnormal, and then obviously the appropriate serological test. So again, I think it's such a brilliant case to really show, as you say, that if things just don't make sense and they don't fit, you really do have to investigate thoroughly. Thank you.
Thanks, Mashiko. That's awesome comment. Wayne, for everybody else, Dr. Wayne Simmons is a gastroenterologist in Bloemfontein. He's head of the division there. I failed to mention Mashiko is head of gastroenterology at the University of Cape Town. Wayne is currently driving the process to write the new gastroenterology guidelines for in patient blood management. So Wayne, go ahead, please.
Good afternoon, everyone. Thank you very much, Prof, for the sobering case and the presentation, Prof Hoffman, for the enlightening talk. It just concerns me a lot as well, you know, that patients like this are picked up so late. Just 2 points I'd like to make. Something that we do allude to in the guidelines is the non-response to intravenous iron, which you very nicely showed, that points towards that the problem is a loss in that instance, and not one of a diet and an absorption. I think that test has proven to be right many times in my practice. And the second point to make is that we often ask the question, or additional point to the ones that have already been made. We often ask the question, which patients do you do a lower endoscopy with B12 deficiency? We know the most common cause is pernicious anemia. So my answer is always a patient having negative serology and whose stomach does not yield the answer for the B12, you have to do the lower endoscopy. So this patient, that's just another point to support the lower endoscopy, and paramount to get the terminal ileum intubation done in this patient. Unfortunately, the lesion was sinister in the colon in this case. Those are my comments. Thank you very much.
Thanks, Wayne. Yeah, and I think, yeah, Mashika and I are also busy discussing another case where a patient was referred for unexplained iron deficiency for GNC scope. And the G scope was done, 3 peptic ulcers were found, and the colonoscopy was cancelled. And 4 months later, the patient was diagnosed with advanced colon cancer. So these bidirectional scopes, once again, I think is really a key issue. But yeah, I think these cases remind us of the importance of the appropriate investigation of iron deficiency. And I think I'm obviously an insider to it, but I am very excited about the gastroenterology guidelines that are coming out. I think it's a really exciting document, and it's going to be very helpful to many people. So again, Wayne, good luck with finishing that project and getting all of us to do what we're supposed to do. That's really great. And also thanks, Chris Castianides. For those who don't know him, he's the man behind the scenes of this PBM Echo program. He's also the power behind the Gastro Foundation, and he's also a gastroenterologist in private practice in Johannesburg, with I think some academic involvements in different places. So great, Chris. Are there any other comments or thoughts for Axel? Axel's got his hand up, his real hand. That is quite nice. Not only yes, Axel, please.
When are the gastroenterology PBM guidelines available?
Well, they're completed. We're just waiting to publish them. Wayne, you've got all your feedback, huh?
Yes, the feedback. I'm waiting for three sort of sets of feedback to come back. So I'm going to send the final reminders, and I wonder if we shouldn't just proceed. I've looked at the preliminary, the figures, and I think we've pretty much reached consensus in majority of the statements. So as you say, they are complete. It's just the last 3 sort of replies that I'm awaiting. Thank you.
Oh, congratulations. So Axel, they are completed. I mean, essentially, they just need it. We know it's the Delphi process that takes the time. I'm hoping we have them ready for some form of presentation at SAGES, Wayne, maybe.
So as soon as they are out, please send me a copy. Let me know well in advance. It might be helpful with our current projects.
Yeah, I can just say things are cooking with regards to patient blood management, and I see a lot of our champions in the audience. Lovely to see you all here. But iron clinics are popping up. Every week or 2, we've got somebody that's really starting to champion the cause in another hospital. And I think the education is really paving the way. Our pharmaceutical partners have really been helping us together with some of the laboratories to get lots of educational sessions sponsored. So good things are happening, and we're very excited about it. Great. So again, a big thank you to Axel for a fantastic talk this afternoon. Really, really enjoyed it, Axel.
Thank you.
And we want to say thank you to all of you who've contributed, who've made comments, who've made the time to be here. Thank you, Cheryl, for your work behind the scenes to organize the practical things. Chris, for driving the process, for your enthusiasm and energy behind patient blood management. And then to, of course, the ECHO, Project ECHO, University of New Mexico, and everything they do to make these things happen. We want to commit, Axel, that as a country, we are totally committed to seeing PBM becoming part of our national health structure and endeavors. And I think the momentum is building. It's not diminishing, it's only growing. And it's awesome to have you as an honorary member of the South African team. So thank you very much.
My pleasure. And by the way, I see a few of my friends here in the audience, Petrolis, Estelle, Vanita, so my warmest regards. Mandy, yeah, I can see a few.
Jake. Yeah,
I
indeed.
have not forget, but my very warm regards to South Africa and to my friends there.
Fantastic.
Yeah.
So on the screen, you can see the ad for next week, Wednesday's ECHO meeting, role of colonoscopy in Lynch syndrome, and the ABC of anal manometry. So sure to be a great session again. So with that, thank you, everybody. I wish you all a lovely evening. Bye-bye.
Bye-bye.
Thanks.
Hi, Axel.
Bye-bye.
Bye, Vernon.
Bye-bye,
Thank
Axel.
you.
Bye-bye, Chris. Bye-bye, everyone.
Bye.